I'm going to show a very interesting case where we did a tear plus ablation. This is a 71-year-old male patient with a Hep B cirrhosis, right lobe HCC treated with a DC beads with AFP more than 5,000. Here we can see a post DC bead case with some scarring and all those things with the portal vein thrombus and the tumor. You can see the PET CT also, and there's exophytic component at segment 6 with partial response. This is an enhancing component where the residual tumor is there. This is a treated component post DC bead case. So we did a lung stenting with a lung stenting fraction of 8.5% through radial approach. Then we proceeded with the tear. Before tear, we decided to treat that exophytic tumor because there is no proper blood supply to that component of tumor. So we decided to burn that with ablation. And after that, after burning the tumor exophytic component, we did a tear with almost 3.4 GPQ to right lobe. As Dr. Baisal sir was telling, higher the tumor dose, the more response is better. We always aim to give more than 120 grays to the tumor. Then only we'll get a good response. This is already followed worldwide, mainly in Singapore. More the dose to the tumor, better the response. So we did a tear. This image particularly shows a blood supply to the portal vein tumor thrombosis. So we have to inject atrium directly into this also. Generalized injection of tumor may not specifically treat this component. So this is a post tear SPECT CT just to see the localization. This is a follow-up after 3 months. You can see the complete tumor necrosis and there is no enhancement of portal vein thrombus. This is a post-ablation changes with no enhancement of the tumor and there is shrink in the tumor size. This is like a complete response. So patient was put on lenvatinib after tear. So AFP till March 2020 means almost 1 year, 3 months was less than 10 milligram, 10 gram per ml. Now recently in March it increased up to 44 and in June they checked again it is 800. Patient had to come for imaging, but almost like 1 year, 3 months the AFP was below 10 nanogram per ml. It's a very good response in a 71-year-old child A patient. So this is open for discussion and we can discuss the same regarding the case. Thank you.
Thank you, Nischal. I mean, we have a lot of questions and I'm not sure, how we're going to take all those questions, but I would like to just answer them in a broad format that a lot of people are still asking questions about how to choose between individual modalities. And I think one of the speakers showed a slide even from the NCCN guidelines that this is more like, many choices are available for patients and for individual centers. So it is here that a multidisciplinary team approach is very important. It depends upon what is your experience with a particular modality and what expertise you have at your disposal for treating these patients. For example, I don't have proton beam therapy. That doesn't hold true for offering that treatment to our patient. Similarly, radioembolization is not available at all centers. So a multidisciplinary team approach is extremely important. A lot of questions are also on the combination of, let's say, nivolumab or other drugs with one of the ablative therapies. So as most of you would agree, we actually do not have any data. There are trials which are currently going on in which combination of therapies are being tried. But unfortunately, we would not have data to say which therapy would outscore over the others. So I hope I'm able to answer a lot of those questions. Now, Dr. Baijal, would you like to add something if you have gone through the questions, if you want to address some things in more general?
So I have answered some of them, the ones that I could. I've typed them out and sent them back. So there were questions on how frequently can you repeat tests. So I said that till the patient tolerance allows, and till you have an arterial access, and of course you are persistently showing tumor kill after each session, you can continue actually virtually unlimited till you can really manage the days. As far as Y90 was concerned, there was a question, I think, on whether we can repeat Y90, but that was already mentioned during the presentation. If I may comment on Nischal's case, I think it was a very impressive result because the tumor was probably virtually pouting into right main portal vein, and we've got 15 months and he seems to be doing well. The ablation access would have been an interesting one because he ablated the exophytic component of it. So was it a direct puncture into the tumor for ablation, or could he get a window through normal liver and find his way all the way to that extreme edge of the tumor?
It was from the treated area into the non-treated areas. Yeah, exophytic. Yes, but we cannot go through the liver. It is a completely exophytic tumor. Even in Seoul and Singapore, they don't hesitate to puncture tumor directly. They say the risk of metastasis in the side areas is very little. They say rare. So I think even exophytic tumors can be treated with ablation, but particularly I nowadays preferring microwave over RFA.
Right.
For better results.
Right. I know. A lot of people would say that, but it does at point. It's a question that we don't give a message saying that it's as good as using transhepatic approaches, but I think your concept of actually treating a component of it, devascularizing it, confirming it as dead, and then using that path as an access was very elegant.
Yes. Thank you.
Yeah, thank you to both of you. I think Dr. Ashwati, would you like to add some final comments? I mean, there's a question on whether SBRT can be repeated, and if so, at what frequency, and how does it affect the toxicity of the normal liver?
So I was just typing out my answer, but I think re-radiation with SBRT is tricky, especially if you have a new lesion which is in a completely different location from the first one, because you have already irradiated some part of the normal liver to a certain dose, and then you're going to be having to address that part because of the new tumor. So typically I would prefer re-radiation if possible with protons, because there you can be much more conformal, much less dose going to the normal liver. So I would say that re-radiation is a particular indication which is very well suited to the physics of protons. If you have a recurrence or a new lesion in which is technically close to your previous treated area, then you can be a little bit more daring because you've already treated that area and you're going into the same area. So you're not damaging new or additional liver, because the liver, we typically don't give any allowance for recovery of the liver. Because we assume that whatever we have ablated to a particular threshold dose is now not functioning liver. So if you're going into the same area, SBRT, repeat sessions of SBRT are possible. But again, I wouldn't advise it within 6 months to a year of the first session. And if you're going into a completely different location, I would be much more careful, because there's a very real risk of causing liver failure or decompensation because you are actually adding on to the previous dose.
Thank